Very good afternoon to one and all. This is Dr. Sangeeta. Welcome back. So today our topic for discussion is ventricular septal defect. So our objectives during this period of discussion is about the ventricular septal defect, the embryology of the interventricular septum, which causes the ventricular septal defect, the anatomical classification of the VSD, the functional classification, the complications of VSD, and the special types of the VSD, the clinical features, echocardiography findings, cardiac catheterization, and what are the indications for surgical closure, what are the indications for device closure, the criteria, and what are the device types. Okay. So introduction. So the incidence of ventricular septal defect VSD as such is 5 to 50 cases per 1,000 live births. It has main of female preponderance. 50% of the VSDs are associated with other congenital heart diseases such as your tetralogy of Fallot, TGA, and the double outlet RV. The topic for discussion today is isolated VSDs. So the VSDs embryology, VSD mainly occurs because of the failure of alignment of the various parts of the interventricular septum, which usually occurs at the 7th week. The formation starts in the 4th week and it completes by the 7th week. So when this components of the interventricular septum fails to fuse, that leads to the 4 main types of VSDs. So which can be a membranous VSD, outlet VSD, inlet VSD, and a muscular VSD. So this picture is showing you an outlet VSD, membranous VSD, muscular VSD, and an inlet VSD. So moving on to the embryology and the formation of interventricular septum. Usually, the interventricular septum is formed at around the 5th week of your intrauterine life. So the septums are usually of 2 types. As we all know, the interventricular septum has a membranous part and a muscular part. So there is something called, this is the muscular part, this is the membranous part. So the muscular part is formed from the endocardial surface of the common ventricle. This is your ventricle. This is the endocardial surface. So the muscular septum is formed from the endocardial surface of your common ventricle. And the membranous portion is formed from the AV cushion, by the proliferation of the AV cushion near your outflow tract of your LV and the RV. So this is the ventricle. This is the outflow tract of your LV and the RV. So the septum formed near here is the membranous septum. This is the muscular septum. So the interventricular septum as such is 4 parts. So it has a smaller membranous portion which fans out and forms the muscular portion. So it fans out into 3 important septums, which is your inlet septum, outlet septum, and the trabecular septum. So this is the small membranous portion which divides and fans out into inlet septum, outlet septum, and the trabecular septum. Okay. So this membranous septum, where it is located, usually this membranous septum is located near the outflow tract of your LV beneath the aortic valve. So membranous septum, we remember it as LVOT, near the LVOT beneath the aortic valve. So this is how we remember the location of the membranous septum. And it fans out into 3 separate septas: inlet septum, outlet septum, and the trabecular septum. Inlet septum is the one which is present near your tricuspid valve, and which is the one which separates your tricuspid valve from the mitral valve. So this separates the septal cusps of your mitral and the tricuspid valve. So inlet septum, which is something which is associated with your AV valves, atrioventricular valves, mitral and the tricuspid valve. This is how we remember an inlet septum. Whereas your outlet septum. So outlet septum is something which is present beneath your pulmonary valve, near your RVOT. So this is the one which separates the outlets of the ventricles. So membranous, we remember it as near the LVOT, beneath the aortic valve. Inlet septum is something which is present near the tricuspid valve, which separates your tricuspid and the mitral. Outlet septum is something which is present beneath the pulmonary valve, near the RVOT area. And next is your trabecular septum. Trabecular septum is easy, which is present near your apex and the body of the LV-RV. So it separates the body and the apex of your LV and the RV. So any defect in the formation of these kinds of septums will lead to those areas of VSD, which is your which can be your perimembranous VSD, which can be your inlet VSD, which is near your tricuspid in the mitral area. It can be an outlet VSD near your pulmonary RVOT area. can be a trabecular septum near your apex and the body, interventricular area. So membranous septum is the failure of fusion of endocardial cushions, conotruncal ridges, and the muscular septum. The importance of knowing this AV bundle which passes postero-inferior to the membranous septum is that post-surgical closure or post-device closure, since this defect area is present near the AV bundle, the AV bundle is present near this defect area, there can be a cause of bundle branch block. This is the clinical significance. And outlet VSD. Outlet VSD is something which is subarterial, which is present near your RVOT. So this failure of fusion, occurs because of the failure of fusion of conal septum. Inlet, again, as we said, it is near your AV valves. So inlet VSDs can be remembered as something related near the atrioventricular valve, which is your tricuspid and mitral valve. Outlet VSD, which is subpulmonary near your arterial valves, pulmonary and the aorta. Membranous septum is below your aortic valve. Muscular septum occurs because of the excessive resorption or lack of the fusion of the walls of trabecular septum, which is near your interventricular area within the ventricular septum. So this is again the picture showing the diagrammatic schematic representations of various sites and locations of the VSD. This is your perimembranous VSD, exactly beneath your aortic valve. Doubly committed or juxta-arterial is an outlet VSD below your pulmonary valve. And this is your muscular VSD near the interventricular septum. And this must be your inlet VSD near your tricuspid and the mitral valve. So moving on to the first type of the VSD, which is your perimembranous or paramembranous VSD. It is otherwise known as the infracrustal or subaortic VSD, which constitutes 80% of the most of the VSDs. So as we said earlier, this perimembranous VSD is present near the outflow tract of the LV, and the conduction bundle passes postero-inferior to this defect. So anterior malalignment between this infundibular septum and the anterior ventricular septum causes the aortic valve to override into this defect. So this type of malalignment, anterior malalignment, is usually seen in the TOF, that is tetralogy of Fallot. Whereas posterior malalignment usually causes subaortic stenosis, which is seen in the interrupted aortic arch. So this is the echocardiographic image showing a perimembranous VSD. So this is your parasternal long axis view. This is your LV, LVOT. This is the aortic valve. This is the area beneath your aortic valve, a defect in this area. So how to identify a VSD is that parasternal shock axis, the aortic valve area, beneath the aortic valve area, when there is a defect in this area, usually it is a perimembranous VSD. So again, echocardiographically, these perimembranous VSDs is seen as a septal dropouts near your tricuspid valve and the aortic annulus, right border of your aortic annulus, as we told earlier. Echocardiographically, these perimembranous VSDs are again divided into 4 types. One is this perimembranous VSD with an absent aortic rim. There won't be an aortic rim at all. Type B will have a thick aortic rim, whereas type C and type D is a septal aneurysm. So there will be a septal defect along with an aneurysmal part. This is a outbulging of the septum into the near the tricuspid valve, which causes the septal aneurysm. Whereas type D is the defect restricted by the tricuspid valve attachment. So usually near the subaortic area, this type C and the type D defects will usually be associated with the subaortic membrane. So this is your LVOT, 5-chamber view, apical 5-chamber view, RA, RB, LA, LB is seen, aortic valve is seen. Below your aortic valve, there is going to be a defect here, which is detected by the collar flow. Below the aortic valve, a defect. Sometimes, usually there will be a subaortic membrane here in the perimembranous VSD. Next is your muscular VSD. So muscular VSD is one of the easiest VSD to identify echocardiographically also. It constitutes about 5 to 20% of the VSDs. It contains 4 regions. It can occur in the 4 regions, which can be apical, anterior, posterior, or the mid-muscular. So this is a short axis view showing a good muscular VSD, shunt flow from the left to right. And next is your Swiss cheese VSD, which is a multiple muscular VSD that occurs because of the septal non-compaction, where the defect in the defect is multiple. It involves all the components of your ventricular septum, almost in the multiple areas, which is extremely difficult to